Hello, good morning, everyone. My name is Dr. Edo Tripon. I'm a hepatologist from the Medical City Liver Center, and I'm very honored to be asked by the SHIP Initiative to discuss with you this morning HIV and hepatitis must-knows in primary care. So here's a brief outline of what we'll talk about this morning. We'll go through hepatitis B and C and the importance and implications of HIV on the course of liver disease in our patients who are co-infected. We'll talk about diagnosing and managing hepatitis B and hepatitis C co-infection in patients living with HIV, and have review the discussion this morning through case examples on HBV, vaccination, pre-exposure prophylaxis, and hepatitis C. So why do we need to evaluate for hepatitis C and hepatitis B in the setting of HIV? So first of all, as we all know, they have the same modes of transmission. They're blood and body fluid borne, so you can get any of the three viruses by sharing needles, syringes, and other injection equipment. You can also get the transmission from mother to child. So from positive mother to a child, you can have HIV and HCV and also hepatitis B co-infection actually increases the risk of passing on these viruses to the baby. In terms of sexual transmission, hepatitis B is much more likely to be transmitted sexually as compared to hepatitis C. But for hepatitis C, the risk of sexual transmission is increased among gay and bisexual men who are living with HIV. Hepatitis B and C are actually the common liver infections among patients living with HIV. Another reason why we need to evaluate for the presence of this viral hepatitis diagnosis in patients with HIV is that viral hepatitis causes faster progression of liver-related health problems among patients living with HIV and those versus those patients who do not have HIV. Liver disease, much of which is related to hepatitis B and C, can cause a lot of the major non-AIDS related deaths among people with HIV. So really it's important to, number one, prevent if possible, diagnose early, and manage viral hepatitis in PL-HIVs. So in terms of the local prevalence, this diagnosing hepatitis B and HIV becomes more important because the Philippines is considered hyper-endemic for hepatitis B. We're 7th in the world in terms of 5-year-olds with HBsAg positive serology. We're also 5th in the world in terms of absolute number of patients or people who are HBsAg positive in the general population. This was a study done in 2017 where the local prevalence of hepatitis B, chronic hepatitis B, was estimated to close to 10%, which translates to about 10 million Filipinos with chronic hepatitis B infection. What about in hepatitis B in Filipinos with HIV? This is a PGH cohort of 655 patients from 1996 to 2014. In this abstract, we see that about 11.6% of PL-HIVs following the treatment hub were S antigen positive. And they proposed that if they included possible occult hepatitis B patients, that it can even be higher, this rate of hepatitis B HIV co-infection in these patients. In terms of HCV and HIV co-infection, this is a systematic review or a meta-analysis of the burden of co-infection with HIV in the region. And this probably is what we have in the Philippines also, a very diverse rate of co-infection. So in high-income countries, they found that their rate was a bit low at 3.8%. However, there are areas in focus populations, such as PWIDs in China, where the rates of HCV, HIV co-infection were over 80%. So just as a background and a review, it's important to discuss the difference of acute and chronic in viral infections. So the reason why hepatitis B and hepatitis C are important is because they can become chronic. So patients can carry these viruses in their bodies and livers for a long time, and this leads to complication. And when it's acute, it means that the carriage of the virus is less than 6 months. So within that 6 months after infection, it's still considered acute. And there's still this possibility that the infection can still resolve. However, if the carriage is more than 6 months, that's what we consider chronic infection. And that's when complications can arise. And these complications include liver cirrhosis and liver cancer, which we see more often actually in HIV. In terms of the natural history of hepatitis B infection, after an infection, after an individual becomes infected, who becomes chronic? So that actually depends largely on the age at the time of infection. So when you're infected at a younger age, there's a higher risk of becoming a chronic carrier. So in babies who are infected by their hepatitis B positive mothers, the rates of chronicity go up to 90%. But if you are in patients without HIV, if you are exposed and infected as an adult, the rate of becoming chronic drops to 6 to 10%. However, it's important to note that in PLHIVs, the rate of incident infections becoming chronic is much higher, up to 20%, even in adults. What about hepatitis C? So in HIV negative individuals, the general rate is for chronic hepatitis C infection is those who get acute infection, about 55 to 80% will become chronic. And the reverse is true for hepatitis C as opposed to hepatitis B. The older you are, the higher the risk of getting chronic infection or carrying the virus for a longer time. But in HIV, you see this rate of clearing hepatitis C spontaneously to drop. So you see that in general, here on our left side, after an acute hepatitis C infection, after you're infected, 20 to 45% can resolve spontaneously. However, in the setting of HIV, only 15% in this cohort clear their hepatitis C virus spontaneously, and 85% of patients became chronic. This risk to become chronic actually worsens in patients who have a lower drop in their viral load within the first 3 months of being infected with hepatitis C, and if their CD4 counts are lower. So this is the natural history of liver disease in someone with chronic hepatitis. If you get prolonged hepatitis B and hepatitis C infection, you can get liver cirrhosis, and it is usually in this setting that you develop liver cancer. Although in hepatitis B, you can get hepatocellular carcinoma even without cirrhosis yet. But in HIV, there is the additional considerations in that if you have chronic viral hepatitis, you should be more wary of drug-induced toxicity from antiretroviral therapy. There's also higher liver-related morbidity and mortality if you have HIV. And there's higher risk of liver cancer, especially in patients who are co-infected with hepatitis B or hepatitis C. Especially in patients who have low CD4 counts, higher HIV RNA levels, and PWIDs. So let's begin by talking about hepatitis B first. So remember, we're talking about hepatitis B in the context of HIV. So we all know this, an S antigen test screens for hepatitis B, and if it is reactive, this is a mark of current infection. So this is the basic important parts of the profile picture, and For S antigen, so HBsAg, if this is positive, this means you have current hepatitis B, while your most durable marker is anti-HB core or anti-HB core total or IgG, because if this is positive, this will be positive in either past or current hepatitis B infection, while anti-HBs tests for immunity, whether from a past infection or from vaccination. This is basically the rest of the hepatitis B profile, but at least remember these three things and ask for these three things because these are actionable parts of the hepatitis B profile. So in terms of hepatitis B prevention in the setting of HIV, in a patient with no prior hepatitis B exposure, and you can mark this with looking at the important basic profile points that I pointed out to you. So your S antigen is negative, your anti-HBs and anti-HBC is also negative. So for these patients, they should be vaccinated against hepatitis B. Ideally, we should vaccinate patients before their CD4 counts are declines to less than 350, but the CD4 count should not be an impedance to vaccination, and we should vaccinate all with HIV at a schedule of 1 month after the first dose and 6 months, the third dose being 6 months after the first dose. The dose is 20 micrograms per ml per dose, although some experts do opt to double the dose, especially if they feel that the immunity is low. And it's important to check that vaccination worked after the last dose, and this is by seeing that your anti-HBs is more than 10 milli-international units or milli-IU per ml. Because if it doesn't work, there's the option to repeat the entire vaccine series. So how about management of the patient who already has HIV and hepatitis B co-infection? So the principles of treatment are this: you start the appropriate ART regardless of CD4 count. And ART that you give should be active against both HIV and HBV. So a tenofovir-based regimen is the recommended therapy because tenofovir is a first-line treatment drug for hepatitis B. So it's either tenofovir lamivudine or tenofovir emtricitabine as our backbone, together with a third drug to prevent the selection of HIV-resistant mutants. It's important not to use a regimen with lamivudine alone because you can select hepatitis B-resistant mutants. So patients on treatment for HBV and HIV should receive therapy indefinitely. So how do you monitor the hepatitis B response to therapy? This is the ideal setting where you look at your DNA at 3 to 6 month intervals after starting a tenofovir-containing regimen, and you monitor a drop in your viral load, meaning your DNA, in 3 months. A complete virologic response is if you get negative DNA in 6 to 12 months. While a partial virologic response is to at least get a significant drop in your DNA in 6 months. You can also consider if a patient is baseline E antigen positive, losing E antigen as a virologic response, meaning your E antigen is positive and after a certain interval of treatment, your HBe antigen becomes non-reactive. But because DNA might not be widely available for us, other markers that indicate treatment success include improvement in liver disease or fibrosis, normalization of your liver enzymes, your ALT, and in those with loss of HBe antigen, the development of anti-HBe. So from E antigen non-reactive and anti-HBe, from E antigen reactive and anti-HBe non-reactive, you seroconvert to get E antigen non-reactive and anti-HBe reactive. So from the antigen, you develop the antibody. The holy grail of treatment of hepatitis B is S antigen loss, and that is quite rare at less than 1% per year. So what are the goals? At least this, expecting a 10-fold drop in your DNA in at least 3 months, complete suppression of DNA in 1 year, reassessment and resistance testing for patients should be considered when you do not achieve these goals. But if your patient is non-cirrhotic and there's no resistance detected, you hope to reach the goal of virologic response within 5 years. However, if cirrhotic and no resistance is detected but suppression is inadequate, you should refer to your colleagues in gastroenterology or hepatology to decide on adding another hepatitis B active regimen to your treatment. Okay, moving on now to hepatitis C in the context of HIV. So what about the hepatitis C burden in the Philippines? So hepatitis C is a smaller issue, but still significant in the Philippines. So if you recall in my slides earlier, the estimate in 2017 was about 10 million infections. In the Philippines, the range of infections for hepatitis C is about at 400 to 600,000 in various estimates. So the special cases in HCV transmission in HIV are this. Heterosexual transmission of HIV is uncommon. However, this is more likely in partners who are co-infected with HIV and HCV. Sexual contact is relatively an inefficient mode of transmission between HIV. However, in HIV-infected men who have sex with men, multiple outbreaks of acute HCV has been documented. Risk factors that increase infection include unprotected insertive intercourse, the use of injection recreational drug use, and concurrent STDs in patients. Also, there's been noted increased incidence in chemsex. MTCT of or maternal to child transmission of HCV occurs in 4% to 7% of HCV seropositive mothers. But when mothers are HIV co-infected, these rates of maternal to child transmission increase to 10 to 20%. So this is the general hepatitis C testing algorithm. It's quite simple. If your anti-HCV or screening test is positive or reactive, you do an RNA to confirm viremia, and that confirms active or current hepatitis C infection. So if your anti-HCV is positive, but your RNA is not detected, then this might mean a past infection and no current infection. However, some caveats of HCV screening in the context of HIV is it'll be good to use a third-generation enzyme immunoassay for HCV infection. So ideally a titer test. If anti-HCV turns out to be reactive or positive, you do RNA testing to confirm viremia or infection. And in general, that's all you need. However, in a patient where you highly suspect a possible acute hepatitis infection, you may want to do RNA testing, especially early after infection and in the setting of very low CD4 counts. You may not detect anti-HCV, but detect occult hepatitis C viremia. So in general, this is also the course of the diagnosis and management for hepatitis C. If your HCV viremia is confirmed, then you proceed then on to treatment. So in the context of HIV, this is hepatitis C management. In 2017, the Department of Health published this circular. And in the circular, it has mandated that all PLHIV shall be screened with anti-HCV. And if positive, an RNA testing is recommended, while if negative, annual anti-HCV screening should be done in patients with ongoing risk. And that in general is most of our patients. HCV treatment should be initiated as soon as possible after confirmed infection. And in patients who have signs of decompensated liver disease, these patients should be referred to a specialist in liver disease. So these are the locally available hepatitis C treatment regimens. Available in our treatment hubs is fosbuvir, daclatasvir in some of our treatment hubs. So fosbuvir, velpatasvir is available in the market locally, both in the innovator brand and the generic forms. I think there are some donated sofosbuvir, ledipasvir, or Havoni still available in some treatment hubs. And given the limited selection of ARVs locally, as well as the limited HCV regimens that we have locally, if available, you can consider sofosbuvir, velpatasvir for genus types 1, 4, 5, 6. So these are the easier to treat genotypes, and sofosbuvir, daclatasvir, so for genotypes 2 and 3. Although sofosbuvir, it doesn't mean that sofosbuvir and daclatasvir will not work for the other genotypes. It's just that sofosbuvir and daclatasvir is what's available because of the higher effect it has in genotype 3. So consider only using sofosbuvir, velpatasvir if you are not on an efavirenz regimen for your HIV. So in the HCV treatment regimen, again, available locally for free in the treatment hubs is sofosbuvir, daclatasvir, which is tablet given once daily for 12 weeks. In the setting of decompensated cirrhosis, meaning cirrhosis with child score C or high B, we extend the treatment to more than 6 months instead of 3 months. HCV treatment may be given with ART. In settings where your ART includes efavirenz, you need to increase the dose of your daclatasvir. And to document cure, so after ending treatment, so at the end of treatment, you count another 3 months and again request for an RNA to document cure. So because if you see that at the end of 3 months after ending treatment, you still have RNA, you need to refer to a specialist for evaluation. So again, as a reminder, daclatasvir, when used in combination with other antivirals, you need to consider those adjustments and drug interactions, which is pretty common when you use ARTs. As a reminder, you need to increase your dose of daclatasvir when you have efavirenz. So the other widely available pangenotypic, meaning it treats all genotypes, is sofosbuvir, velpatasvir, and maybe this will eventually be available in our treatment hubs. We don't use this with efavirenz, etravirine, or nevirapine. Velpatasvir has the potential, it's important to remember this, that the velpatasvir can increase our tenofovir levels. So the side effects of tenofovir, including renal toxicity and bone toxicity, can be heightened if you use tenofovir and velpatasvir together. So in general, we try to avoid using TDF in those with GFR less than 60. And if ever you have patients who have renal compromise or kidney issues, you may use tenofovir alafenamide as an alternative to the TDF or tenofovir disoproxil. So tenofovir alafenamide is basically a new version of TDF, as you know, which decreases the exposure of the kidneys to tenofovir. So these are the no-nos in treating patients with HIV and HCV co-infection. You do not need to interrupt ARTs just to allow HCV therapy. So it's a matter of looking for the correct regimens that will have acceptable drug-drug interactions. And we've discussed the important drug interactions earlier. For those using sofosbuvir, ledipasvir, or Havoni, the abbreviated or shortened dose regimen of 8 weeks is not recommended, even with lower HCV RNA viral loads in patients with HIV co-infection. So what do we do after curing the hepatitis C in our co-infected patients? So in patients with cirrhosis and patients with advanced fibrosis, you have to make sure that they continue to follow up with their gastro or liver doctor to make sure that liver cancer screening is continued every 6 months, and that's with an alpha fetoprotein blood test and a liver ultrasound. So these tests should be continued even if HCV RNA is now negative. And the important thing is we know that we're dealing with high-risk populations with continued exposure. So it's important to know that cure does not protect you from reinfection. So anti-HCV is not a protective antibody. And this is why we need annual hepatitis C assessment with HCV RNA to document reinfection. So for the next few slides, we'll just wrap up and review and get a better, hopefully a better grasp of the discussion by going through some cases. So the first case I'll discuss is a 55-year-old male. He's a professor diagnosed with HIV for the past 10 years on lamivudine, tenofovir, and efavirenz. He has multiple high-risk exposure, multiple MSM partners, occasional IV drug use, and family history of diabetes. Incidentally, his mother had liver cancer, and 2 brothers are hepatitis B positive. So when you see a family history like that, consider the possibility that your patient also has hepatitis B being infected by the mother at birth. So the patient also drinks alcohol nightly. These are his ARTs. And incidentally, for some reason, stopped his ARTs for, he can't remember, for 6 months to a year. And then this patient decided to come back to hub, and baseline tests now showed elevated liver tests. His ALT is 150, his AST is 95, so both are elevated with an upper limit of 40 in the lab. His platelets were low. And again, S antigen, incidentally, was documented to have been positive since 2015. So this is a patient with HBV HIV co-infection. So what's the baseline assessment of someone with viral hepatitis? You look at the history. Are there any signs of liver-related symptoms? Did he bleed before, have jaundice, encephalopathy? Does your patient have high-risk social history? Does he smoke? Or does he or she drink a lot of alcohol? Is there high-risk family history? Is there anyone in the family with viral hepatitis or liver cancer or cirrhosis? And in our patient's case, this was positive. Also assess for baseline risk for renal dysfunction. So these are patients who are diabetic, with known kidney injury before, hypertensive. So look for co-infections in particular. So check for Hep B and Hep C, and look for comorbidities that might cause injury to the liver. Diabetes, obesity, dyslipidemia can lead to higher rates of fatty liver. The presence of alcohol-related liver disease, and drug-induced injuries. So in your physical exam, pay special attention to signs of liver disease. Is your patient icteric, jaundice? Is there ascites? Is there an abnormal abdominal exam? Is your patient encephalopathic, or is the patient with asterixis or liver flap? So in our patient, if you recall, our professor, these are the pertinents for him. The family history, the alcohol consumption, the risk of having fatty liver, together with his hepatitis B and HIV. So these are the baseline examination tests that we should go through. So check kidney function with creatinine, standard or checking tests, liver enzymes. You can evaluate liver function through checking your albumin, INR, and bilirubin. Check rigorously for co-infection. In a patient with signs of acute hepatitis, you should check for acute hepatitis A and test for immunity to hepatitis A, because if your patient is negative, you should vaccinate. For assessing the virus, if it's Hep B, you assess your DNA. If you have the luxury of doing e-antigen anti-HB, you also add on to that. For hepatitis C, of course, you document viremia. Also, in terms of assessing the status of the liver, you can do tests for fibrosis, and that's FibroScan, LiverFast, and APRI. We'll walk through that later. And do liver cancer screening when appropriate through ultrasound and blood test, AFP. So this is what we have for our patient. His ALT and AST were elevated. His platelet count, sorry, that AST should be 95. His platelet count was decreased. He had normal liver function. His hepatitis B S antigen was reactive. And when they checked his antibody for hepatitis A was already reactive. So when he checked his hepatitis B DNA, it was elevated at 25,000 IU per ml. And on the ultrasound, it was noted that the patient had signs of liver cirrhosis, course and echo pattern of the liver, waving, liver borders, no mass, so no overt sign of a liver tumor, and a normal alpha fetoprotein, which is the tumor marker for liver cancer. So if you remember the values earlier, this is how we check for cirrhosis through using the APRI score. So for the APRI score, you just need your AST, your platelet count, which we had in this case. And in this case, if you plug in the AST, so you get an APRI score of more than 2. So when your APRI score is more than 2, the chances of having liver cirrhosis is increased. So this patient most likely has cirrhosis. We have evidence based on his ultrasound and his APRI score now. Other options is this. So for example, if our professor had the opportunity to do a special blood test, this is a LiverFast score, which has in it the fibro test. So the fibro test gives us a blood test marker also for cirrhosis. And in this case, a score of more than 0.75 is considered diagnostic for liver cirrhosis. And that was also confirmed for our patient. This is another test that's available. This is a FibroScan. So it's an ultrasound-based technology that can be done to check for cirrhosis and also check for the CAP score, which measures the presence of fatty liver. So in our patient, the cutoff usually for cirrhosis in the liver stiffness measurement is more than 12, and our patient score is 23. So that gives him a score of F4 fibrosis or liver cirrhosis. His CAP score was also increased. So he had severe steatosis. So the normal liver fat is less than 5%. And based on this FibroScan test, you can see that he is S3 or with more than 66% liver fat. So consider liver cancer screening. So this is an important part. So who do you screen? Patients who are Hep B positive and over 40 years old, especially if they're male, especially if they have HIV co-infection, should be screened for liver cancer. Patients with family history of liver cancer, patients with cirrhosis, so like our patient, patients with hepatitis C who have advanced fibrosis, so even F3 and F4 cirrhosis, even after we cure the hepatitis C, these patients should be screened for liver cancer at 6 months interval. So back to our patient, he was referred to a hepatologist. An ART regimen containing tenofovir was continued. He was advised every 6 months liver cancer screening, regular follow-up, and DNA was fortunately documented to be undetectable in 1 year. Diabetes was monitored closely, and patient had compensated or asymptomatic liver disease but continued follow-up. So we advise this patient liver healthy lifestyle choices to avoid alcohol, to stop, to avoid doing hepatotoxic drugs, and that includes even over-the-counter medications, pain relievers, herbal and natural therapies. You advise patient to stop smoking. We advise the patient to go on a healthy weight and exercise regimen to address the fatty liver. And if your patients do not have hepatitis A antibody, please vaccinate them. In the case of if this patient had maybe HCV co-infection and was anti-HBs non-reactive, then you vaccinate them for hepatitis B and advise to have regular liver checkups aside from their HIV follow-up. So what about PrEP, pre-exposure prophylaxis, and hepatitis B? We have a 32-year-old seafarer who's interested in PrEP. So he was S antigen reactive on the screening test. So it's important to note that being Hep B positive is not a contraindication to starting PrEP. However, you should advise the patient not to stop his PrEP without informing the healthcare practitioner, because this is especially important for this patient because he mentions that he wants to stop PrEP when he returns to sea. So for our pre-exposure prophylaxis precautions, always screen for Hep B and Hep C when you do this. Vaccinate for hepatitis B if still anti-HBs negative. If S antigen is positive and with chronic hepatitis B, advise them abrupt stopping of their PrEP if they're not on Hep B management yet, could cause flares, and flares may be catastrophic and even fatal in patients with baseline liver cirrhosis. And in fact, you should not stop hepatitis B treatment in patients with cirrhosis. So how do you work up hepatitis B in the setting of PrEP? It's actually the same as what you would do with chronic hepatitis B. You assess the liver disease. You assess if your patient has cirrhosis through the measures we discussed earlier, do liver enzymes and liver function tests, and also assess viral replication using your DNA. So what if your patient has hepatitis B and they decide to stop PrEP? You watch out for relapse. So relapse can mean your S antigen or E antigen becomes positive from being negative, your DNA rises, or from undetectable becomes detectable. And sometimes if these above tests are not available, patients can present with increasing ALT levels. If you document a relapse, then retreat your patient with a Hep B antiviral. So how do you monitor if the patient is insistent on stopping? So ideally, and you can discuss this with them before they start their PrEP, that if they ever stop, they need to be monitored monthly in the first 3 months after stopping, then every 3 to 6 months thereafter to monitor relapse. And you should check at least ALT and signs of clinical decompensation and DNA if possible in these patients. So that's it for PrEP. Now we'll discuss hepatitis B vaccination. This is a 33-year-old male, a musician with a history of complete vaccination 10 years ago. As he recalls, his 3 years ago, his titer for anti-HBs was less than 100, and he doesn't recall having a booster. His partner, both he and his partners are HIV positive. Both are S antigen negative on screening. So you check the anti-HBs titer. If it's less than 10, you advise him to get a booster. And then you check anti-HBs after 1 month after giving the booster. If the titer is less than 100, you should consider completing 3 doses as if giving the primary series. Lastly, let's discuss hepatitis C outside IBDU. So this is a 25-year-old male, PLHIV, on LTE for the past 2 years with multiple casual partners, some of them with IBDU. So he came into the hub, no symptoms. His ALT was 350, AST was 122, a marked rise from his previous values last year. So you decide to screen for viral hepatitis. S antigen was negative. However, there was a seroconversion and his anti-HCV became reactive from negative. So what do we do next for this patient? We checked for viremia. And then you see that RNA is positive. You check the kidney function. Creatinine is normal. The liver ultrasound is normal. He's able to do a fibroscan and it's normal, so no cirrhosis. He's not able to do the genotype because of the cost and wants to get free treatment from the treatment hub. And he was treated then with sofosbuvir, daclatasvir, for 12 weeks, at the same time monitoring his creatinine. And for the daclatasvir dose, in this case, was increased because he was on efavirenz. So for this patient, after 3 months after ending his treatment, they checked the RNA and he turned out to be non-reactive. And then this patient was advised to do RNA every year. So thank you very much. I hope you learned something from the discussion this morning. So I'll be happy to take questions.